We're going to move on now and we'll keep questions, and I'll look at the chat line now and any questions that have come through and answer that on my lecture. But we'll move on now promptly to Professor Eddie Leen, who's going to address liver contrast enhanced ultrasound and the guidance and periprocedural assessment of ablation therapies. Eddie, please.
Thank you very much, Paul. First of all, let's talk about the different types of ablation. It's largely classified into two, thermal and non-thermal. The thermal one is the classic microwave ablation or radiofrequency ablation. There's also cryoablation, which is freezing the tumor or using HIFU to actually burn the tumor. But I'm going to talk mostly about microwave and RFA as they are more commonly used in practice. Of the non-thermal techniques, we have the chemical ablation, which is really the old-fashioned way of using alcohol or acetic acid to ablate small hepatocellular carcinoma. And this is already have been, we've stopped using that for the last decade, really. Now, the other relatively new non-thermal technique is really irreversible electroporation, which is really the kind of way of electrocuting the cancer cells. So it's only the cells that get killed using very high voltage across two needles. Now, in terms of doing the procedure, we can do it intraoperatively and usually in combination with a surgeon, or percutaneously as we do for interventional radiologists. So for percutaneous approach, it's either done under general anesthesia or heavy sedation and analgesia, depending on patient condition, obviously. And we tend to use a combination of both ultrasound and CT combined to do liver ablation in general. MR is very difficult because we don't really have MR compatible equipment in general. So this slide here illustrates the three main modalities that I'm going to talk about. RFA, radiofrequency ablation, and you can see different sizes of needles for different sizes of tumor that we want to ablate. And this is the microwave generator, and again, single size needle, but the choice of ablation zone size depends on the power that we use and the duration of the ablation that we apply for the procedure. And this one represents the irreversible electroporation generator. And usually we use a combination of two needles, although in the past we had used bipolar single needles. First of all, what are the indications for ablation? It's really mainly used for colorectal cancer with liver metastases. It is used as an adjunct to liver resection in combination with the surgery at the time of the operation, obviously. And clearly, there are also those patients who are unsuitable for resection, usually less than 3 to 4 centimeters. And that's largely because of inadequate surgical margin or liver reserve, or because of coexisting morbidity. There are patients who can't undergo further chemotherapy because of cardiotoxicity or neuropathy, and these we can control the disease with multiple stage ablations. There are also slow-growing tumors like the neuroendocrine metastases, and these can be done again over several stages without fear of having to chase the growth of the tumors. The other category of patients that we do ablations in the liver metastases are from breast, melanoma, and renal carcinoma for oligometastasis, meaning when the number of lesions are small and they're less than 3 centimeters in diameter, and most importantly, if the disease has been stabilized by systemic treatment over a period of 3 to 6 months. The other large category of patients that we do ablations, obviously, are the hepatocellular carcinomas. These are patients with limited HCCs, not suitable for transplant or resection, and that represents about 30 to 40% of the cases that we do. The BCLC, which is the Barcelona Clinic stage A1 to 4, are included in this group. There are also patients who are awaiting liver transplant or liver resection, and usually these are patients filling in the Milan criteria, that is single lesion less than 5 centimeters, or 3 or less in numbers, but less than 3 centimeters in diameter. With regards to the larger hepatocellular carcinomas, those with the CLC B1 and B2, we use a combination of both TACE, which is transarterial tumor embolization, or SERD, and if there's any residual disease after these embolic treatment, we then apply microwave or RFA to the residual disease. How do we use CEUS for ablation? There are really 4 main tasks, really. First place is this staging, that is detection and characterization. The second is really the targeting of the metastases, especially trying to guide needles in the larger lesions where multiple needle placement is required. This slide here, Paul has already talked about, which is the detection, improved detection of the liver metastasis. As you can see on the baseline scan, it's very difficult to pick up any of the individual lesions in the liver. And as you can see with the contrast enhanced scan, these occult lesions are much clearly visualized. And in this particular case, there are multiple lesions. And these patients, obviously, having detected so many more lesions is not really suitable for further ablation, given the numbers of lesions. So this, the management had to be changed to patient going back to systemic chemotherapy. Now, we do also detect more lesions intraoperatively. When you think about, intraoperative ultrasound for a long period of time has been the gold standard in terms of detection of the metastases, and yet in this particular study, we've actually shown that even in intraoperative ultrasounds, contrast adds more information in terms of detection as well as characterization. And you can see from this series of video on the left side here, you do see the rim around, the halo around the lesion, but this can change depending on how much pressure you apply with the ultrasound probe. But with contrast, you can see much clearly the lesion size, border, and so forth. Now, one classic thing we do intraoperatively is we use our hand to palpate the lesion, especially if they're subcapsular. Sometimes we can feel it, but we can't see the lesion. And therefore, how do we go about to guide the ablation if we can't see it? And here's the advantage of contrast. You can see it may not show very well on your screen, but certainly there's this clearly demarcated small metastasis in the subcapsular area compared to, better seen compared to the IOS on cell. And in the study of 90 patients, which we published in Surgical Oncology many years ago, this was actually the first paper comparing contrast intraoperative ultrasound versus intraoperative ultrasound itself. Out of the 87 patients, we've shown the change in management in 25 patients, that is about 29% of patients, largely because of additional lesions in 21%, and largely again because of better characterization, because some of the other lesions were actually benign. And of the additional lesions that we've seen, we actually applied radiofrequency ablation in 3/4 of the patients. They're avoiding extra segment resection. So it changed management in a significant number of patients. In terms of characterization, one of the common things we've seen in patients that we've ablated before is how do we distinguish metastasis from previous ablation zone? On the grayscale, you can see there are many lesions, but which one is which? Well, the outcome to us on the CEUS scan, quite clearly you can see metastasis enhanced, and the ablation zone remains dark throughout both arterial and portal and late phases. And obviously, when they wash out, one thing we can do is re-inject to see the arterialization of the tumors again. But you can see residual circulation in the metastasis, whereas the ablation zone are completely devascularized. And that really facilitates and really make it easier in terms of doing the procedure. The other thing with patients we've had multiple courses of chemotherapy is the fatty change that takes place in the liver. And that leads to focal area sparing, which can simulate metastasis. And as you can see here from these static images, what would look like metastasis because of the hypoechogenicity of the lesion. Following contrast administration, there is equal amount of contrast within the fatty change as with the adjacent liver, and hence this is what we would call a pseudo lesion as opposed to metastasis. And the other classic one is really benign hemangiomas that have been misdiagnosed on CT scan. And as Paul had explained earlier on, the disadvantage about CT scan is just a slice in a one-time zone, whereas with CEUS scan, which is a dynamic real-time imaging, you can actually see the full dynamic enhancement of the hemangioma here. As you can see, the peripheral nodular one here, we see at the early stage of the injection. And as we go to as the portal late phases, is filling in the tumor classic hemangioma, and this patient did not need any ablation. Now, one of the things about doing the ablation is a question of choosing the right size of needle for the to make sure that we cover the whole tumor volume. It's not a problem when the tumors are less than 3 centimeters, but when the lesions are in between 3 to 4 centimeters, we really need to know the true size of the lesion. And that's the advantage of using contrast. The ortho phase is not always very accurate, but when we wait for the late ortho and late phases, you can see the true margin where the washout has taken place. And obviously, we want to ablate beyond that margin to ensure that we don't get any local recurrence. This slide here is really to illustrate the advantage of using the dual screen. Just bear in mind that on the grayscale, when you place in the needle, you can see on the fundamental mode, the needle itself, but on the contrast mode, the needle itself is subtracted unless you move it, as when we do the biopsy here, you can see as the biopsy is shot, we can actually see the needle quite clearly. In the same theme, as I mentioned earlier on, the combination of TACE and ablation has shown to improve overall survival in patients with intermediate and large size HCCs by me and colleagues. And other authors like Leen and Hirokura also showed, even for early stage disease, that the combination of TACE and RFA improves survival. And in this video here, this patient had already had TACE, but you can see there's residual disease inside the HCC, this large HCC. The enhancement is seen here. The needle is approached. You can't see the needle is subtracted, but you can see the needle on the grayscale fundamental mode here coming in. And this is the post-ablation to show the complete devascularization of that residual disease. And you really need contrast to be able to do that kind of treatment. Now, the next series of slides, we're just going to show the difference when using microwave, RFA, or IRE. So as a startup, pre-CEUS, pre-ablation CEUS, we identify the lesion. We want to know the size and the configuration of the tumor itself. Once the washout here, the needle has been inserted here. This is the microwave needle. Now, bear in mind, in the microwave needle, what you want to see is the nidus, that is the junction between the ceramic and the metallic component of the needle. And that has to be in the center of the lesion. So you really want to track the echogenic component here. And as you can see here, it is subtracted, right? But sometimes another clue to identify the microwave needle on the contrast mode is there is flow through the needle, all right, to core the needle. So sometimes you can see those flash, and that will guide you to see the alignment of the needle itself. So that's the ablation taking place. And this slide here really shows the post-ablation zone. You get this peripheral hyperemia, which is inflammation around the dark area, which is the ablation zone. With microwave, what we tend to see is, especially when we've used with ablated for a long period of time, we actually see shrinkage of that ablation zone. Unlike when we do RFA, which I'm going to show in the next series here, again, pre-contrast, we do see the lesion. Lesion is better seen on the contrast mode. The needle is then inserted here. But what we do looking at in RFA is not the active component. We're looking at the tip end of the needle. We want to place the needle beyond the margin, just about 5 millimeters beyond the margin of the tumor. And that's when we start doing the ablation. You can see the cloud burst here on this video. And a few minutes later, this is what on RFA, the ablation zone, completely devascularized, very sharp margin, and still some benign peripheral hyperemia, which is reflective of inflammation. Okay, we can do the same process intraoperatively. As you can see here, the probe is right on the surface of the liver. It's pretty hard to see this metastasis here, but with contrast, so much easier to see. And that's important because we want to be able to place the needle accurately. So this is one of the needle that's deployed as one of the Boston needle. And as you can see again, we can do the post-ablation contrast to see the ablation zone, whether it's complete and whether it overlaps the original tumor. Now, when and why do we use irreversible electroporation for ablation in the liver? It's largely for safety purpose. So the indication is really for lesions which are lying at the hilar area, because we want to protect the common bile duct. In the subcapsular, because we want to avoid pain, because that's where most of the pain fibers are. And again, if any lesion nearby the gallbladder or the bowel tract, like hepatic flexure, or sometimes the duodenum. And again, with large vessels, it's to prevent the cooling effect of the vessel itself. So that's when we would use the IRE. And there have already been published papers showing the effectiveness and long-term survival using IRE for liver metastasis in the region of 49% overall survival. And others have shown the technique to be useful and more effective in hepatocellular carcinoma compared to colorectal liver metastasis. Now, the only thing I would say about the IRE is it is quite difficult to actually see the needle as we approach the target. And that's largely because the stem of the needle is much thinner. Okay, so you only see by you only recognize it by 2 dots. So once the ablation takes place, we do see one of the active needle where there's a bit of electrolysis. We can see that's how we see the active component of the needle, and the movement that you see is really when the pulses are being delivered and there's movement despite patient have been given muscular relaxant. Immediately post IRE, one thing we see is that there is still maintenance of the macrocirculation of the tumor, and this only disappears 10 minutes later. But the first thing we notice is the swelling of that ablation zone. It looks so much bigger, and literally 10 minutes later, we then see complete devascularization. We're ablating a more proximal lesion. That's how we managed to get a look at the previously ablated lesion. And again, you can still see the mark of one of the track of the needle. And again, you can see the lesion revert back to its original size. But that's the ablation zone, what it looks like for the IRE. One of the common local recurrence following surgery, as you can see, this patient has previous right hepatectomy. There's a large tumor here, which is sitting by the left portal vein. And again, you really use RFA or microwave to ablate because there's always a danger of causing damage to the vessel wall and creating severe hemorrhage. Or it could be inadequate ablation because of the cooling effect of the main vessel flow. This is confirmed on the PET scan. And again, on the 3D color scan, we can actually see the lesion again. And this was one of the early cases we used. We used a bipolar single needle IRE. This is the track of the needle you can see here. And already during following the pulses delivery, there's still maintenance of the microcirculation, but which in time disappears. This is the effect, pre and post effect. There's shrinkage. This is one thing we see more often with IRE compared to RFA or microwave is the involution of the ablation zone, which is much quicker in the case of the IRE. Another example of where we use the IRE, this patient had a large tumor which was unsuccessfully ablated by RFA. There's the residual disease noted by the vascularity within the ablation zone. It was in a tricky location, it's just underneath the heart. You can see the heart, this side here, left hepatic vein sitting right anterior to the large metastasis. We applied the needle, 2 sets of needles, which you can see inside the previously ablated zone. This is during the delivery of the pulses. And this is the effect post ablation. We get devascularization of the whole tumor. 6 weeks later, post IRE on the same patient, again, we're looking at complete devascularization of the tumor, and again, also involution of the metastasis. How do we recognize local recurrence? patient had a previous ablation. You can see the ablation zone clearly here, but we see this area of hyper-enhancement during the arterial phase and washes out in the portal phase. And that is the classic sign for local recurrence or residual disease for that matter. Okay. We did apply a 3D acquisition over that ablation zone to look at the geometry of the recurrence, and you can see how extensive local recurrence have been around previous ablation zone here. So two things we want to look, what is the comparison between RFA microwave versus IRE? For complete coagulation, the key thing is really complete loss of enhancement. That is the main component. The assessment of volume size can be tricky because, as I said to you, with microwave, it can become smaller rather than bigger compared to RFA. The margin is certainly sharper with the thermal techniques compared to IRE, which remains ill-defined. But the main component main characteristics about looking for residual disease is really the enhancement in the arterial phase and the washout in the portal phase. Bear in mind the difference between benign hyperenhancement, which is the enhancement around the periphery because of inflammation that persists throughout all phases of the ultrasound scan. We in the UK do not use contrast as such for surveillance post-ablation. We only do a 4 to 6 week checkup to see whether there's any residual disease. But in terms of longer term follow-up, we use CT scan or MR scan for colorectal and hepatocellular carcinoma respectively in the UK. Whereas I know in some Scandinavian countries, they use CEUS scan to do surveillance of liver for colorectal cancer, as well as HCC. One of the great use of ultrasound with bubbles is really to look for complication after the procedure. And we do often see subcapsular hematoma. And really what you want to see whether this hematoma is stable and that there is no active bleeding. This case here, as you can see, although large, is stable, didn't require any intervention. But if you look at this case where there is active hemorrhage, we must have hit one of the arteries during the procedure. And that was confirmed on the angio, which we did straight away, as we noticed this thing. And we embolized that segment artery. Here you can see this new enhancement on the angiogram. And this is the post-angiogram embolization CEUS scan showing slightly larger hematoma, but there's no active bleeding anymore, which meant that the embolization has been very successful. So in summary, ablation therapy now is in routine practice in most hospitals nowadays in the UK. And I certainly found that the CEUS scan is an essential tool in the staging process, the targeting of the needles, and assessment of the periprocedural response, and also in the follow-up 4 weeks afterwards. Thank you.
Thank you, Eddie. Just to let everyone know, we're going to move on to the next speaker before questions and answers. But if I could just let you also know that you'll automatically receive an email with a link to the recording and a short survey in the next few days. And you can re-review the webinar at any stage. And you can request also a participation certificate.